I think we'll get started. Thanks for being here. My name is Sukhpreet. I'm the Associate Director for the Addiction Medicine Fellowship. Um, as you know, this is our What's New in Addiction Medicine series. I was looking at the numbers. This is number 111, so it's been going on for a while. Um, and it's always a good chance for us to talk about you know new but also sort of established topics in addictions and sort of related fields. And I think this one's particularly topical. I'm sure everyone's seen the news around the upcoming election, the sort of contention around supervised consumption spaces, what those mean for communities, what the sort of rhetoric is about their potential for harm and how that's conveyed. And particularly what gets lost is that these are not unstudied topics, but these are things that have been known and evaluated. And I think it's an opportunity to reflect on what we know and what we don't know and what the utilities are. So I'm very happy to introduce Dr. Ceire Storey, who's one of our addiction medicine fellows this year. She's also a fifth-year emergency medicine resident at Queen's University, so she's about to finish off a very long road of training and hopefully will join us here in Vancouver, maybe. And she's going to be presenting on an overview of supervised consumption services. Take it away.
As mentioned, my name is Ceire Storey, and I'm going to be doing an overview of supervised consumption services. First, I want to respectfully acknowledge that I'm a humble guest on the unceded homelands of the Musqueam, Squamish, and Tsleil-Waututh nations. This here are the learning objectives for my presentation. And first off, I want to start with an overview of an update of Canada's current opioid crisis. So Canada continues to experience an unregulated drug toxicity crisis, primarily involving opioids. We have seen substantially elevated numbers of opioid-related deaths and harms since the national surveillance began in 2016 by the Public Health Agency of Canada. There was over 47,000 apparent opioid toxicity deaths reported between January of 2016 and March of 2024. The COVID-19 pandemic has exacerbated the crisis as several jurisdictions reported higher rates of fatal overdoses and other harms following the onset of the pandemic. During the first year of the pandemic, so between April of 2020 and March of 2021, over 7,000 deaths were reported, which is a 96% increase from the same period the year preceding the pandemic. Since 2016, as I mentioned, there have been over 47,000 opioid-related deaths, over 44,000 opioid-related hospitalization, over 180 opioid-related emergency department visits, and over 216,000 EMS responses to suspected opioid-related overdoses. I want to highlight a few key updates from this year. So this is data between January and March of 2024. Of note, most of the accidental apparent opioid toxicity deaths have occurred among males, so that's 72%, and among individuals aged 30 to 39, which is tallied at 31%. The 2024 BC Coroner's Report summary shows that the cumulative numbers of unregulated deaths in 2024 is over 1,300. This represents a 9% decrease in the number of deaths during the first 7 months of 2023. Currently, the annual death rate in 2024 is less than the annual death rates in any of the previous 3 years. In 2024, 69% of those dying were 30 to 59 years old, and 73% were male. 81% of unregulated drug deaths occurred inside, with 48% of those being within a private residence, 33% being in other inside residents such as social and supportive housing, SROs, shelters, and hotels. And 18% occurred in vehicles, sidewalks, streets, and parks and other outside spaces. There's only ever been one death reported at a BC-based OPS, and that was in 2022. So supervised consumption sites and overdose prevention sites are important harm reduction strategies, and access to supervised consumption services is considered part of the standard of care for people with opioid use disorder. Despite this, there's currently significant controversy surrounding this approach to the ongoing opioid crisis and the proposed alternatives. I chose this topic to provide an update on the relevant evidence. So supervised consumption sites provide sterile drug use equipment for people to use pre-obtained drugs in a safe and clean space in the presence of trained staff. They also provide a range of services to comprehensively address drug-related harms and the social determinants of health. At a site, a person brings their substances to the site to consume, and depending on the site, they can either inject, snort, inhale, or consume as pills. Trained staff are available to help if there's any accidental overdoses, and the needs of the community determine the hours of operation and the types of services that are provided at each site. The type of staff varies from site to site, but generally, it includes nursing staff, social workers, and peer and community support workers. So I want to go through a little bit of the history of supervised consumption sites. So the first supervised consumption site opened in Switzerland in response to the escalating HIV pandemic in 1986. In 1995, the Vancouver Area Network of Drug Users opened Canada's first OPS, which was operated by community members who use substances. It's been operating on and off for nearly 30 years. In 2001, Australia launched their first supervised consumption site. And then in 2002, there were some nurses at the Dr. Peter Center who recognized the need for supervised injection services. They had gone to their nursing regulation and determined that it was within their scope of practice. And they began offering supervised injection services at the Dr. Peter Center in 2002. In 2003, the government sanctioned a three-year pilot project, which led to the opening of Insight in Vancouver. But then unfortunately, from 2008 to 2011, the Canadian Conservative government took Insight to the Supreme Court of Canada in an attempt to shut it down. All 9 judges ruled unanimously that the attempts by the federal health minister to close Insight went against the country's Charter of Rights and Freedom by threatening the safety and the lives of people who use these sites. In 2015, the Conservative government introduced new legislation known as Bill C-2, which is called the Respect for Community Acts, that provided 26 stipulations that had to be met in order for a supervised consumption site to be legally opened. After the Liberal government came into power, a new bill known as C-37 replaced the existing bill C-2. So it replaced the 26 conditions that needed to be met with only 5 conditions that needed to be met. So the primary goal of supervised consumption sites are consistent across sites worldwide, although the design and the operation of each site can differ based on the local needs and the context in which they operate. The goals generally include to help save lives by responding to overdoses quickly, to connect people to health services such as primary care, mental health care, substance use treatment, to help prevent the transmission of infectious diseases, and to bring stability to the community by providing public order and reducing consumption taking place on the streets. So, as I said, supervised consumption sites offer a combination of services and supports to comprehensively address these goals. Typically, they can provide access to clean drug use equipment and a place to safely dispose of this equipment, witness consumption of unregulated substance, emergency care in the case of allergic reactions, overdose, cardiac arrest, basic health services such as things like wound care, STBBI testing, safer drug use education, naloxone distribution and training, drug checking to confirm the contents of a drug sample, and then referrals to other healthcare teams and social services such as housing, food, and employment supports. Since January of 2017, every federally exempted supervised consumption site in Canada regularly reports its data to the Health Canada. As of April of 2024, there have been 38 unique supervised consumption sites offering their services within Canada. More than 446,000 Canadians have visited a supervised consumption site 4.8 million times, between January of 2017 and May of 2024. During this time, workers at these sites have reversed over 58,000 overdoses and provided patients with over 515,000 referrals to various health and social services. In March of 2020, Health Canada began a standardized reporting format with more detailed information coming from these supervised consumption sites. So over 41,000 overdoses occurred at supervised consumption sites, with over 17,000 requiring naloxone, but no fatal overdoses occurred. Over 833,000 referrals were made to within the supervised consumption space. Over 58,000 referrals were made to services off-site, and then over 151,000 referrals were made to on-site. So that would be things like the community health centers who have different services within that same building. Lastly, I want to point out that most clients using the supervised consumption sites identify as males, and for all genders combined, the most common age group was 30 to 39 years old. If you remember from my previous slides, both Health Canada and the BC Coroner's report that most opioid-related accidental deaths are occurring among males between the ages of 30 and 39 years old. So this data shows that we are targeting the right population. In Canada, supervised consumption operators undertake an extensive application process to receive a federal exemption under the Section 56.1 of the Controlled Drugs and Substance Act to protect its participants as well as its staff from drug possession charges. Obtaining this exemption is a lengthy process that requires a detailed site description, a review of the proposed policies and procedures, community consultation, letters from the municipal government and other stakeholders, and data that demonstrates the need and scientific evidence behind this site. This process has been criticized as burdensome and delaying of life-saving interventions, which is where the overdose prevention sites come in. So the first overdose prevention site that opened in Vancouver was in the late 2016s without any federal exemption or any approval from any government, in response to rising overdose deaths, bureaucratic delays, and government inaction. It was actually initiated by a group of volunteers who were running a street market on the downtown east side, and were responding to increasing overdose within the public spaces of the market. So they had actually set up an outdoor tent to allow people to safely use substances and allow for more controlled response to the overdoses that were occurring. Other non-authorized sites later emerged in Toronto and Ottawa, again, without any federal exemptions or any government approval. But in 2016, the BC Minister of Health enacted a ministerial order to support the implementations of overdose prevention sites across the province without seeking any federal exemption. So the order was issued under the province's Health Emergency Service Act in the context of a public health emergency, and that was declared in April of 2016. So this allowed for rapid sanctioning, implementation, and scale up of the OPSs provincially, with over 20 OPSs opening within the first year. In December of 2017, Health Canada gave all provinces and territories the ability to apply for a class exemption, and granted the power to approve temporary OPSs based on urgent need without requiring federal government approval and that lengthy application process that I spoke about earlier. So supervised consumption sites and overdose prevention sites share many features, but there are some important distinctions. As I just mentioned, the supervised consumption sites gain federal approval after a lengthy application process, which ensures stability and more permanence. In contrast, the OPSs operate legally through the provincial government and are established on a temporary basis in order to respond to urgent needs in a specific region, and therefore can be set up relatively quickly, but they also face potential closure if the public health emergency is declared over. While government documents describe their focus and services as distinct, in practice, there appears to be minimal difference in the types of services that are offered between the two. So this is a website. It's called Pivot. I thought it was pretty interesting because you can go in and put in your location and it will show you all of the supervised consumption sites and overdose prevention sites in your area. So when you're talking to your patients about harm reduction, it may be a good idea to kind of run through specifically where it is that they can go to use their substances. In Canada, there's currently 38 federally approved supervised consumption sites that are actively offering services, with 8 additional sites currently pending approval. And in BC, there are 60 active provincially sanctioned OPS sites. So given the complex legal, cultural, economic, and epidemiological questions, a mix of qualitative as well as quantitative approach is important to fully explore this topic. Canadian and international evidence shows clearly that supervised consumption services help to save lives, to connect people to social services, and to serve as pathways to substance use treatment. So existing scientific evidence supports the role of supervised consumption sites in reducing deaths for people who use drugs because people are not rushing or using alone. After the opening of Insight in Vancouver, there was a 35% decrease in overdose deaths within a few blocks of that facility, compared to only a 9% decrease within the rest of the city. Globally, there have been no recorded fatal overdoses in supervised consumption sites, but you will remember I did mention there's been 1 death in an overdose prevention site. A study performed in BC in 2002 to evaluate the population level effects of both OPSs and SCSs on acute health service use and mortality found that the mathematical model of individual and combined impacts of BC's recently implemented or otherwise expanded harm reduction interventions estimated that 5% of deaths were averted by OPSs alone. People who use drugs often experience significant barriers that delay or prevent access to traditional healthcare services and social services. Supervised consumption sites provide a unique point of contact for healthcare providers or social workers to link people to resources through referrals and wraparound services at these sites. Evidence specifically shows that supervised consumption sites may help increase uptake into substance use disorder treatments and other programs. Therefore, supervised consumption sites can provide an important opportunity to help address people's health and social needs that might otherwise go unaddressed in the community. Unsafe drug use includes using drugs in public, rushing drug use, sharing, borrowing, or reusing drug use supplies. But supervised consumption use has been associated with lower rates of risky drug use practices amongst the people who use drugs via safer drug use education and environmental conditions that support safe use practices. A meta-analysis of 3 studies estimated that supervised consumption use was associated with a 69% reduction in the odds of syringe sharing. Compared to people who use supervised consumption sites occasionally, people who use supervised consumption sites frequently may also have lower rates of unsafe drug use practices. And this is important for health because unsafe drug use practices can increase the risk of harms such as overdose, injection-related infections, and bloodborne infection transmission. Ultimately, the evidence suggests that supervised consumption sites play an important role in reducing health risks for people who are using substances. So next, I want to talk about cost savings. Many stakeholders are interested in whether research examining supervised consumption supports these services as being cost-effective measures. Globally, there are 20 studies that have reported on whether implementing supervised consumption sites have saved or will save the government money. Interestingly, there are seven of these studies happened here in Vancouver. And the remaining studies assessed sites in other Canadian and US cities. All of the studies found that supervised consumption sites save money. However, there's less agreement across the studies on exactly how much money is being saved and whether these savings can be directly attributed to the supervised consumption site services or similar services such as like the needle and syringe distribution program. Estimated savings resulting from insight range from 200,000 to 6 million annually, depending on the modeling approach and the variables that they included. So clearly there's a lack of agreement regarding the extent of what we're saving, but the consensus is that the site is saving money overall. There's been economic evaluations of 2 unsanctioned OPSs here in Vancouver that have also identified that OPSs provide overall cost savings. And this is also further supported by prospective studies on the potential savings associated with implementing new supervised consumption sites in other cities across Canada, as well as the US. The opening of supervised consumption sites and overdose prevention sites has also been shown to decrease the burden on our already overwhelmed healthcare system through reducing the amount of opioid-related emergency department visits and EMS calls. So opponents of the proposed supervised consumption sites are worried that crime and public disorder will worsen in the surrounding areas. But most of the available peer-reviewed research found that supervised consumption sites do not increase crime and actually can help improve public order in the surrounding areas. So compared to before a supervised consumption sites have opened, many studies have found reduction or no change in public drug use in areas like streets, public washrooms, and parks. Observational research from Vancouver measured less public injection after Insight opened. And in Australia, residents and business owners near the supervised consumption site noticed less public injection. However, one peer-reviewed study in Kamloops found that residents and business owners perceived increases in public drug use around a supervised consumption site. In 2022, a systematic street observation of indicators of drug and homelessness related nuisances in a 500-meter radius around a newly opened OPS with another comparison point in the city before and after the opening of the OPS was performed. They had found that the risk of reported nuisance on a sidewalk surrounding the OPS decreased by 7%. The risk of drug-specific nuisance was similar to the comparison area, and the risk of homelessness-specific nuisance decreased around the OPS, showing that the implementation of the OPS does not increase the prevalence of visible signs of drug use or homelessness within the area. A number of studies have found fewer publicly discarded needles around supervised consumption sites after these services have been opened. Publicly discarded needles were found to be significantly decreased in the surrounding blocks after Insight had opened in Vancouver. And other research shows that people who frequently use supervised consumption sites may be up to 6 times more likely to safely discard of their needles compared to people who are not using the supervised consumption sites. Research has also found decreases or no change in violent crime after supervised consumption services have opened. So police recorded violent crimes decreased by 6 crimes per week in the neighborhood that contained Insight after the facility opened, and there was no significant decrease in crime in other areas of Vancouver at that time. Other Vancouver-based research found that incarceration rates among people who are frequently using these supervised consumption sites were similar to those of people who were not frequently using these supervised consumption sites. Again, showing no increased rates of crime among people who are accessing them. The majority of studies investigating the relationship between supervised consumption site and drug trafficking have found no changes following the opening of a supervised consumption site. Police data has shown no difference in the number of drug trafficking charges after Insight opened in downtown Vancouver. A handful of studies in Canada and Australia have found reductions in robbery and theft offenses following the opening of supervised consumption sites. Police recorded property crimes decreased by 35 crimes per week in the neighborhood containing Insight after the facility opened compared to other areas in Vancouver. The previously mentioned systematic street observation in San Francisco found a decrease in the risk of reported nuisance on the sidewalks surrounding this OPS. However, some Canadian and Australian residents, as well as business owners, have stated that they felt that there were increases in loitering and other public nuisances. So now I want to take a moment to acknowledge the gaps in our current knowledge surrounding these supervised consumption services. So as I mentioned, we kind of talked about what we do know, but now let's talk about what we don't know. So at this time, there's limited longitudinal research on the long-term effects of these sites on community dynamics. The effectiveness of these sites can vary based on the local context, on the implementation strategies, on the services offered, and community engagement. So more research is needed to understand these different variables. There is a gap in understanding how public perception of these sites are formed and sustained, particularly in relation to the actual evidence of their impacts. The role that the media narrative has in shaping public opinion and policy is also not well understood. The media often focuses on negative stories and sensational incidents rather than the broader public health benefits presented in the literature, leading to skewed public perceptions. The media also tends to oversimplify complex issues of substance use disorders and harm reduction, and they often highlight the public's fears or concerns that are not supported by research, which then influences the public's opinion and creates a narrative that conflicts with what the evidence is showing us. So a few proposed recommendations to fill these gaps would be community level studies focusing on the community level impact of the OPSs and SESs, incorporating qualitative data from residents, law enforcement, healthcare workers, and the people who are using these sites. Comparative studies across various regions with different implementation models to identify factors that contribute to successful implementation of these OPS and SESs. And we need to investigate how different media outlets are reporting on supervised consumption sites and overdose prevention sites, and analyze the influence that these reports have on public perception as well as policy decisions. So in-hospital substance use is common among patients with substance use disorders to avoid withdrawal, to avoid undertreated pain, to avoid negative feelings and stigma. In many cases, it's unrealistic for us to expect a patient with a substance use disorder to stop using substances during one of the most stressful times of their lives in an unfamiliar environment and when their social supports have been cut off. Despite the high prevalence of active substance use in acute care settings, most hospitals continue to enforce an abstinence-based policy, leading to riskier substance use practices, increased rates of patient-initiated discharges, readmissions, and deaths. Unfortunately, harm reduction interventions have not been widely accepted in the inpatient setting at this time. In Canada, there are currently only 2 hospital-based supervised consumption sites. So one is in Edmonton at the Royal Alexander Hospital, and the other one is at Casey House in Ontario, and 1 hospital-based OPS here at St. Paul's. So the goals of hospital-based supervised consumption services are to reduce the number of unwitnessed overdoses on hospital grounds, to reduce the number of code blues called for required overdose resuscitation, to prevent opioid-related mortality among individuals who use substances while they've been hospitalized, and to support patients to remain in hospital to receive medical care. So here at St. Paul's, we have the Thomas Donaghy OPS, which is funded by Vancouver Coastal Health and operated by Rain City Housing staff. So to address the ongoing high overdose death rates, St. Paul's Hospital implemented North America's first hospital-based OPS in 2018. When the site first opened, it actually opened as a tent in the St. Paul's Hospital parking lot and then was moved to the basement of St. Paul's. At this time, they offered IV route only, and it was open to both inpatients as well as community members. It was staffed by peer support specialists only. In February of 2021, the OPS moved to a site just across the cafeteria on the 4th floor. Again, IV route was the only way that people could use their substances. And at this time, it was only open to inpatients, emerge patients, and patients who were attending outpatient appointments. So it was no longer open to community members. At this time, it was staffed by LPNs who had access to RNs if needed. In 2023, there were 68 code blues calls that occurred in the cafeteria washrooms, as well as on the rooftop garden, with the majority being unwitnessed overdoses from patients who were smoking substances. That year, the BC coroners report that more than of the more than 2,500 lives lost to drugs, most deaths, so they reported 65% of deaths, were as a result of smoking. Accordingly, St. Paul's Hospital expanded the scope of their services as well as the location to allow for both injection and inhalation, becoming the first site to offer inhalational services in an acute care setting. It's currently staffed by 6 peer city support specialists and 1 Providence peer support coordinator. So this peer-led model aligns with other community OPSs by decreasing the potential barriers to use, facilitating trust and confidentiality, and eliminating the added healthcare strain. Before the expansion, the injection-only OPS averaged about 6 visits per day, but since the expansion to both inhalational and injection services, they're averaging about 46 visits per day, with 81% of those visits being for inhalation. Again, it's only open to inpatients, emerge patients, as well as patients who are attending outpatient appointments. And their hours of operation are 7 days a week between 12 p.m. and 8 p.m. Between July of 2019 and February of 2024, the OPS has seen 6,600 visits and had the highest overdose rates among all OPSs operated by Vancouver Coastal Health, with no deaths occurring. All of the peer support workers are trained in advanced overdose management and assist with overdoses in outdoor spaces. They monitor for overdose and call code blues if required. But over the last 3 years, more than 95% of overdoses have been managed within the OPS itself without requiring a code blue response. So the services that we offer here at the St. Paul's OPS are overdose management and intervention, take-home naloxone kits and training, access to safer drug supplies, including clean injection as well as clean inhalation supplies, and then safe needle disposal, harm reduction education, peer support, and drug testing for both fentanyl as well as benzos. So this was a retrospective chart review of patients from May 2018 to June 2019. This was from the first OPS site, so the site that opened as a tent and then moved to the basement. Over 11,000 visits occurred, and the monthly number of visits more than tripled within the first year. Among all OPS visits, 20% reported being inpatients of the hospital, with this number increasing over time. 39 overdoses occurred, which represented approximately 0.3% of all visits, and none were fatal. So inpatients who access OPS were found to be at a significantly higher risk of experiencing overdose compared to the community clients who were using this OPS. They proposed that this might be to a loss of tolerance due to hospitalization, resulting in overestimation of the safe amount that they would be able to use, acute illness, and then concurrent opioid and other sedatives that were prescribed in hospital for either acute pain or withdrawal management. I think this highlights just how important hospital-based supervised consumption sites and overdose prevention sites are for people who are using substances while they are admitted to hospital. So this was another paper that was done here on our OPS, and this was the second iteration of the OPS. So this was the one that was across from the cafeteria on the 4th floor. The paper describes steps leading to the implementation, its impact and lessons learned, but I'm going to be focusing more specifically on the impacts that this OPS had. So between February and October of 2021, the OPS recorded over 1,600 visits, and a total of 46 overdoses were recorded in that 9-month period. 80% of those overdoses required naloxone, and 26% required a code blue response. We know that nearly 45% of those code blues happened within the OPS, which speaks to the positive impact that it's had. However, as many code blues occurred when the OPS was closed. Potential reasons for the remaining code blues include lack of awareness of on-site OPS, inability
Testing, mock code pink OR. Testing, mock code pink OR. Testing, mock code pink OR.
So potential reasons for the remaining code blues that had occurred when the OPS was remaining code blues for the OPS was lack of awareness that there was an OPS on site, an inability of patients to leave the unit, or the fact that inhalation was their primary method of consumption. So while research is focused on the health outcomes related to supervised consumption services, these do not necessarily capture the full human impact of these services. The purpose of this study was to add depth of the understanding through narrative analysis of the experiences of people who use these facilities and how these facilities have influenced their lives. A critical narrative method was used and centered around photographs. So there was 16 individuals who were accessing this OPS, took photographs, and then participated in interviews to describe the impact that the site had on their lives. And there were 4 themes that were proposed to constitute a core narrative encompassing the diverse experiences that these participants had. I want to leave you with a few photographs and a few quotes from each. So enduring represents the experiences of the participants prior to accessing the site and their experiences that continue when not at the site. It reflects the sorrows, trauma, despair, and hopelessness experienced in the midst of chaotic substance use. However, as they eloquently shared, their lives were also characterized by strengths. In the midst of this suffering, they found creative ways to survive. From a public health perspective, the key priority of supervised consumption services is to reduce the risk of infectious diseases and minimize the risk of death from overdose through creating safe, clean, and secure physical spaces for people to use substances. However, in addition to physical safety, participants talked about more than being safe, but also feeling safe. This is where the title of my presentation came from. They described how the site served as a safe place where they could be free of stigma and judgment, where the stresses of the chaos of living with substance use were quieted, at least momentarily. Connecting and belonging were central to the experiences shared by participants at the site. I think these quotes really speak for themselves. Participants came to the site looking for physical safety, but also discovered a deep sense of belonging and even transformations. These transformations were seen in substance use practices, health and well-being, community participation, and hope for the future.
Recovery, COMOC unit. Code white, road to recovery, COMOC unit. Code white, road to recovery, COMOC unit.
They, the public, need to know what this place is offering people and how it's changing people's lives. It's not promoting use, it's providing a safe place if you choose to do so. And they have all the avenues to help you get out of your slump. And they have the connections to get you into treatment. They encourage you if you choose to do so. Thank you. You could fill out the survey. We would appreciate it.
Questions?
Any questions? Yeah.
On the St. Paul's OPS and how many clients have used it for inhalation purposes versus injection?
There is data. It's not published yet, but they are working on that. Yeah.
Do you happen to know if the OPS is like if they're in the process of applying for it to become an SCS?
So the question was whether or not I know if the current St. Paul's Hospital OPS is applying for the application to get funding for the SCS designation. I don't know the answer to that right now. There is kind of an evaluation right now ongoing for both qualitative and quantitative data on the OPS, which I think would facilitate the application to the government, but I'm not sure at this time.
For clarification purposes, but can an SES have inhalational options? Are there any SESs in Canada that have inhalational?
So the question was whether supervised consumption sites are able to have inhalational services. Yes, they are. You have to, again, go to the government and get approval for that. I don't know specifically which ones have inhalational services, but there are some in Canada that have inhalational services available. I don't know if you know.
Yeah, there are like that.
Yeah, the problem becomes when like an occupational health and safety standpoint, the bar for NCS is just higher.
Yeah,
that's when personnel who are employed by health unions.
I guess then you hope to help in relation. I feel like that's an SCS.
Yeah.
So actually hope to help have the inhalation. Yeah. And it's about to open or already open?
It's just open. It's actually really cool too, because for the inhalational room, they have a button where they can push on the wall that immediately evacuates all the smoke within like 30 to 60 seconds, so that healthcare workers are then able to respond to any overdoses that are needed.
I'm
Miriam,
unmuted. Can you hear me?
I can hear you now. Yeah.
Hi, Dr. Storey. That was an amazing presentation. Thank you so much. What a great review of the history of OPCs and SES in Canada. My name is Miriam Harris. I'm an internist and addiction doc, and I'm based in Boston, but trained in BC. So love joining these presentations. Thank you for always inviting us. My question for you, and this is based on the fact that I will be one of the co-medical directors of Rhode Island, soon to be opening OPC, which will be the second OPC in the United States, is how do we respond to the political backlash to OPCs and the media coverage, which I think in some ways is different and valid. I'm familiar with the literature, and I think the literature around needle discarding, violence, etc., is true, but it's also old and particular to certain OPCs and communities. And the context in which we're in, where there's a severe housing crisis, and a crisis of not enough healthcare services in general for unhoused folks and people who use drugs does mean I think that the traffic and use around OPCs has changed. And how do we honor that and the community's concerns with what we know about OPCs? Because I'm very worried about what's going to happen when we open and the community backlash.
So I think to speak to part of your question, you did mention that a lot of that research is older, which I agree. Again, I was trying to do a lit review, and the most recent research that I found was from 2002. So I think that just highlights the fact that we need more research on our current sites to kind of go back against what the media is portraying and the public's concerns. Again, in one of my slides, I also mentioned about how I think we need to do more analysis on the media itself and how they are able to shape public opinion as well as policy decisions. I by no means am an expert in any of this, so I don't think that I can fully answer that question for you. Any other questions? Thank you for coming.